Miss Nancy, we'll allow Mr. Keith to vote this evening, and we'll revisit this. I'm sorry for the late notice. That was when I received the information, so I just passed it on to you as soon as possible.
Thanks.
You're welcome.
Are we ready to start yet?
No, ma'am. No. They changed the systems. We've checked it and rechecked it, but we have had a few IT issues this evening. Just, you'll hang tight just 1 second. I'll let you know. Thank you.
Got dedicated members. Deborah Thrower's in her car, it looks like.
Thank you.
And Carol Broussard, I know, is at the hospital. So this is above and beyond. Thank all of you for joining us.
Okay, Miss Nancy, we're good to go. I appreciate your patience.
Okay, we'll call the meeting to order. First item is to call the roll. Deborah Thrower is in her car. Keith, Donna Broussard, Carol Broussard.
Here.
Mia LeMaire is absent. Mary Jane.
Here.
Angela. Matt Dugas.
Here.
Clyde Stansberry.
Here.
Michelle Broussard. Shannon Crumblish is excused. Butch Mouton.
Here.
Shannon Thomas. Burnell.
Here.
And Katie Landry.
I'm here.
1, 2, 3, 4, 5, 6, 7, 8, and we have a quorum. So we'll proceed. The Insurance Committee is meeting via Zoom in accordance with Act 302 of the Legislature and Louisiana Revised Statute 42:17(1). Public comment was solicited via email prior to the meeting tonight in the public notice, and a link to watch the meeting is on the LPSS website by clicking on YouTube. Anyone wishing to make a comment during the meeting should call 521-7064. And that's for the items about which we will vote. Items about which we do not take a vote, we don't need public comment. First item on the agenda, is there a motion to approve the agenda and consider each item on the agenda?
So moved.
Motion is made by Clyde. Is there a second?
Butch, second.
Butch, seconds. Trish, are there any emails or phone calls?
No, ma'am, there's not. But I know you have to, I'll put my timer on for 30.
Yeah, we're not waiting 2 minutes. Somebody can dial in a matter of seconds. So 521-7064.
There's just a delay. Yes, ma'am.
All those in favor?
Aye.
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 Opposed?
Miss Nancy.
Yes.
There is a 30-second delay. I confirmed it with IT. So we'll need to wait a total of 1 minute in order for public comment transitions.
So how many more seconds do we have, Trish?
We're almost there.
Technology is just wonderful.
When it works.
And in the interim, I also need to identify everyone who is on the Zoom call. That's required under the statute. So it is Trish LaBeouf from the Insurance Department, Irma Trosclair, Butch Mouton, Lynn Fontaine from Hub, Brooke Brunet from Hub. Who is S. Boyd?
She is the accountant here at LPSS. Heidi LeBourgeois is transitioning, and she's the new. Miss Susanna is the new one.
Okay. She is on. Clyde Stansberry is on. Billy Guidry is on. Donna Broussard is on. Matt Dugas is on. Burnell Lemoyne is on. Deborah Thrower is on. Carol Broussard, John Mouton, Mary Jane Woods, Keith Johnson, Jennifer Gardner, Katie Landry, and a bourgeois. Who would that be, Trish?
That's Miss Heidi. So Miss Heidi's transitioning out of the position. Miss Susanna is positioning in.
Okie dokie. So I assume we can say all those in favor again of approving the agenda and each item on it?
Aye.
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 Anyone,
Aye.
anyone opposed? So the minutes will reflect that each member voted in favor of the
Got it.
agenda.
Okay, got it.
Second item are the minutes. They were prepared by Donna Broussard. Thank you very much, and distributed by email from Ms. LaBeouf. Is there a motion to approve the minutes?
I make that motion.
I'll second. Butch.
Butch and Clyde again?
Yes.
Or Clyde and Butch? Clyde made the
Clyde and
motion.
Butch.
Butch.
Are there any emails, Trish?
No, ma'am. No, Miss Nancy.
Are there any phone calls to 521-7064?
Not currently. I'll let you know when that time is up.
I'm gonna get the timer. I got a timer. Who thought a minute could be that long?
I'm getting there.
You just have to have a margarita machine on the side.
I've got a timer, Trish, thanks. We're at 10 seconds. 521-7064. All those in favor say aye.
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 Is anyone opposed? So the minutes will reflect that each member voted in favor. Next item on the agenda is the election of new members. We have a couple of vacancies. The first vacancy was Child Nutrition Services. Mrs. Morrison gave the proper notice at a board meeting of the vacancies. And the active member who is interested in representing child nutrition is Melanie Abear. Is there a motion to nominate Melanie Abear to join this committee representing child nutrition?
I'll motion.
Donna
Second.
Bruce, is there a second?
Who's second?
Butch or
Butch.
Butch, yeah.
Okay.
Trish, are there any emails or phone calls?
No, ma'am. Not currently. I'll let you know if they are.
So I've already started the timer, so 521-7064. And Trish, if you would, if anybody else joins the meeting, would you let us know so it can go on the record as well?
Yes, ma'am.
Thank you. I don't know if I said Ms. Gardner was on, but she is.
Yeah, you listed it. You listed her.
Okay. All right, all those in favor of Melanie Abear representing child nutrition on the committee, say aye.
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 Is anyone opposed? So the minutes will reflect that each member voted yes. The next two vacancies were for retirees at large. I was contacted by two individuals who were connected to organizations. So they could not be considered, they were not retirees at large. One of them indicated to me that she might change her status with the organization, but she would let me know. I did not hear back from her since July. So the only two applicants that we have are Phyllis Bartlett and Vicky Seo, our former member, who would like to be back as a retiree. So do I have a motion to nominate both Phyllis Bartlett and Vicky Seo for the 2 vacant retiree at large positions on the committee?
I so move Burnell.
Burnell made the motion. Is there a second?
Katie will second.
Katie seconded the motion. Are there any emails, Trish?
No, ma'am. I don't believe my email is listed. I tried to look at your certificate to make sure. I believe yours is listed, Miss Nancy, but it was prior to the meeting start. And just for record, I would suggest roll call votes for the proper record.
Well, she's recording it by roll call.
Per member? Okay.
Yes, recording it.
Right,
All right, so we'll wait our minute. 521-7064.
Okay, what was Vicky's last name you said, Miss Nancy?
Vicky Seo, S-E-A-U-X. She was
okay.
former child nutrition,
Okay, I know who that is. Okay,
been on the committee for a long time,
okay.
and missed us and wants to come back.
Okay.
Bless her.
I did receive a text from Ms. Bourgeois. Her speakers are working, but her microphone is not. She's the accountant for the fund, just FYI.
Okay, thank you. Time is up. All those in favor, say aye.
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 Is anyone opposed? No, so the minutes will reflect each member voted yes. So I will notify those 2 of our next meeting, which brings us to the next agenda item. I'll call on Mr. Fontaine. I don't think we need to vote on this. Our bylaws require us to have quarterly meetings. We want to have those meetings when Mr. Fontaine has had a quarter worth of data that he can give to us. So I asked Trish to have Mr. Fontaine present the dates of the quarterly meetings. They'll all still be on Tuesdays at 5:30 as the committee has already requested. So Lynn, do you have those dates for us?
Trish, I had some dates on hold for you guys. So.
No, those were the dates in case we couldn't meet tonight. But
Okay, well, I mean, I can give you some dates right now, Miss Nancy. Third quarter is close of September, so we'd be looking towards the end of October. It has to be on a Tuesday.
Tuesday, yes.
Okay, so October 26th.
Okay, and that would be for what, for third quarter?
That would be third quarter through September.
Okay. Then the next?
We'd be pushing into November. Are you talking about year end or another date?
Yeah, I'm talking
Year
about.
end.
Okay. Oh shoot, I'm gonna have to get January. We should be pretty open though for January. I can tell you that right now. I don't have any meetings scheduled in January. So if we do the last Tuesday in January, I'm not sure of that date. Let me see. That would be
Last Tuesday is the 24th. I'm sorry, the 25th.
So October 26th for the third quarter, January 25th for the fourth quarter,
for the fourth quarter. Yes, ma'am.
and for the first quarter of 2022?
Oh, you need a whole year's worth of dates?
Correct.
Oh,
That's
I'm
what
sorry.
That would be April the 18th.
And
Yeah,
that would be,
I would do April the 25th because the data is going to drop. So we do April 25th.
Right.
April 25th is the first quarter, and the second quarter, please.
Okay, and then we'd be.
Hey, Brooke, keep into consideration we have open enrollment and voluntary benefits too. So we will likely need information in July with regard to voluntary. So depending on what your next date is.
Okay, so mid-year data through June, be looking at probably August the 8th or July the 25th. What date would work?
It would be closer towards either the beginning or the middle of July. We'd have to start thinking about open enrollment and voluntary benefits and whether anything needs to change or have discussions with regard to it too.
Okay, so if July 18th will not work because the data will not be available.
So Ms. Nancy, if that's the case, you may need to add a July in there perhaps based on voluntary and open enrollment.
When will the second quarter data be available, Brooke?
It doesn't, June data doesn't drop until the 15th. So it kind of, if we do it any earlier than the 25th, we won't have full data.
So we can do it July 25th?
July 25th, but the data won't be available until the week in prior. So the report won't be available until about the 22nd of July. And I know you guys would like it ahead of time, but if we run the meeting that early, it doesn't give us enough time to analyze it and go through it like we need to.
Trish, what is the date?
July 25th is a Monday,
I'm sorry, the 26th.
and April 25th is also a Monday.
So it should be April 26th, Matt?
6.
Yes.
Yeah. I wrote down the Tuesday date.
Okay.
Ms.
So-
Nancy, any open enrollment changes would have to go to the board in August, so we would need some sort of discussion in July if we have any changes with regard to voluntary.
Okay, Trish, so what if we did July 26th? Brooke,
July 26th would work. We'd have the data by the end of the prior week, so we'd be ready by the 26th. Yes, ma'am.
and that's okay with you, Trish?
I'd have to do a double check with EBI. Typically, when we discuss open enrollment, it's the first or second week in July, and that may be too late. Can we tentatively list that date and I can circle back to you and follow up?
Sure. So the dates for our meetings, this doesn't necessarily mean we're not going to have additional meetings, but I was told that we needed to have our dates for the year set. So those dates are October 26th, January 25th, April 26th, and July 26th.
Yep.
Okay, next item is
Ms.
the,
Nancy,
You had,
yes, ma'am.
I apologize. Ms. Mia has joined the meeting. She joined about 5 minutes ago.
Great, thank you very much. Next item on the agenda is the HUB report. I had several calls today. For those of you who have not checked your email today, the page 5 of the report we got from HUB yesterday was changed to a different, part of it changed and was replaced with a new version today. And I understand Mr. Fontaine is going to explain those changes. Lynn, if you could you start by tonight, instead of going through all of it first, could you start by reading the last page first? What your recommendations are.
My recommendations for the cost-saving strategies?
Yes, read those first, and then let's go back and see what's transpired and what changes occurred.
All right. Cost-saving strategies are on page 33.
I'm sorry, Lynn, tell me what page again?
It's the last
33.
page.
It's 34 on my copy, Lynn.
Yeah, the first version, it was 34.
I'm sorry.
That, which brings up another subject. Do we get to see the first version? I had emailed Trish earlier to see if we could get a copy of version 1, which we haven't.
Oh, there was no version 1. Version 2 was really just for my reference. It was what I saved it as, and I think that might be where the confusion came in. But the first version that you have was the first version. It was just internally saved on my hard drive that way.
Okay, thank you.
Sure.
So page 34, Lynn, the cost savings.
All right. So we've spoken in the past and at last meeting, we wanted to have some cost saving strategies prepared in the event that we had some uptick in claims and needed to interject some cost saving strategies to bring the plan into financial order. The first 4 bullets are benefit changes. In going through the reporting, these first 4 bullets are probably more designed for maybe a second phase of cost saving strategies to be implemented either mid-year or on or after the first of 22 there. The next 2 bullets could well be implemented for 1/1, and obviously they have much more financial impact. As we've spoken in the past, in order to reduce plan costs, we can always change benefits. We can always go up on premium. Those 2 items are not necessarily our last resort, but when we can look towards changing items in the plan that don't have an effect on a benefit or have an effect on a payroll deduction or increased premium, those are more are to our advantage. So the first bullet is, of course, increasing the enhanced calendar year deductible from $800 to $1,000. Projected savings are $200,000. Increasing the basic calendar year deductible from $950 to $1,250, saves $500,000 projected. Increasing the medical out-of-pocket on the enhanced plan from $4,750 to $5,500, $160,000. Increasing the basic plan medical out-of-pocket from $5,500 to $6,000, saves us $220,000. The next 2 bullets are not benefit changes. Blue Connect is a program or a network that Blue Cross has with the Ochsner affiliates. Blue Connect network with benefit steerage means that if we were to design some benefit steerage over and above where your current benefits are, for example, a little lower copay, a little lower deductible, little lower out of pocket. So where in your current benefits, no plan member would lose anything if they went to any of your current PPO providers. But if we steered towards the Ochsner providers and we were able to get an overall decrease, and we have looked at this on several other cases, and that medical claims net savings has been averaging about 4%. Based upon your 2020 medical claims, that projected savings is about $1,300,000. That would not have any negative impact on your employees because none of your current benefits would change. It's just if we designed a better set of benefits to steer towards those facilities where we have the best discounts. That's what the Blue Connect strategy is all about. And of course, you see the potential of $1.3 million of savings there. The next one is to renegotiate and market our pharmacy benefit program. Projected savings based upon the 2020 prescription drugs could be anywhere from 5 to 15%. 5% represents about $1,020,000. 15% representing $3,055,000. We would utilize our pharmacy consultants. They would take the plan specifications and our claims and shop that amongst the pharmacy benefit managers out there and negotiate, and hopefully and one of the criteria would be not to have any type of, we want to utilize the same formulary so we're not changing the list of drugs and things like that. So This would not be something where the pharmacy benefit managers would all be proposing formulary changes. This is basically to renegotiate and maximize our discounts and our rebates. Your size case and the larger case market, there are pharmacy benefit managers that have put together some consortium pricing or direct to a CVS or Express Scripts, those types of larger pharmacy benefit managers, direct deals that can give us anywhere from 5 to 15%. This type of leverage could also provide for increased discounts and rebates from our current pharmacy benefit manager, RX Benefits. So that does, those two do not have any impact on benefits or premiums, and have the potential to save a couple of $1 million or more. And then, of course, I wanted to, at least on the last bullet, show you what a 5% increase to the participants would garner, and that's $760,000. That's basically for information purposes, not really recommending any type of premium increase at this particular time, and, unless none of these saving strategies would be implemented.
Lynn, is that all? Is that 5% just proposal, or what you're recommending? Not recommending, but proposing. Is that across all three, basic, enhanced, and high deductible?
Yes, sir.
Okay, good. Thank you.
Lynn, this is Burnell. I'm just asking a question. Are these things that to be considered? Or are you expecting any of these to be approved?
These are all for your consideration.
Okay.
I believe with the performance of the plan, that it would be highly recommended to move forward with either Blue Connect, the pharmacy benefit management, marketing, or both.
Well, if your plan, if you would like that done, I think I would move to have another meeting so that we can find the very specific. Are you expecting this to be done tonight?
All we would need tonight would be agreement to move forward with these items, and we would come back to committee, especially with regard to pharmacy benefit management. We would be coming back at the next meeting to present results and finalists.
Okay, and at that point, then the committee would either approve or disapprove.
Correct.
Because I mean, too many times we do it the night of, and then come back and say that there was no change, but then in the end result, there are several changes. So that I can understand that you find out more information about it, then come back. We could have a special meeting to consider, because if it's to be done tonight, I would move that we have another meeting sometime soon together. But I understand if you want to get the information and come back before the committee, I understand that.
Correct.
Thank you.
Lynn, on the PBMs, okay, is that changing our partners, or what would that what would it involve?
If you did make a change, and on the agreement of that change, basically a change of card.
Okay, because let me tell you what's happening with me. Last year, and this is just one of my drugs. Basically, it was $10. Okay, and then the next one, I do 90-day strips for maintenance. It was $10. Then it went to $19, and then now it's $29. Okay, and it's a common medicine. It's not one of these crazy. It's just a maintenance medicine for something that's very common. How are we doing with this new program as far as for retirees on Medicare?
We've done quite well. We've had some good savings, and we've heard very little complaint from it.
Okay. Well, I've had some the people that I deal with from our Acadiana group. They're telling me that their drugs the drug cost has increased and whatnot. And of course, when I went through this, I just finished doing something called Good RX, and I'm
Right.
finding what I did the research and whatnot, and anybody can do this online. My 90-day script on a lot of my medicines, okay, and for example, I have one medicine that's like a 75 milligram. Well, they don't make that, so I have to get the 50 and then the 25. So it's 2 scripts and it's X number of dollars. But I'm finding out that the 90 days that I'm paying for, I can get it through Good RX for 180 days for the same price I'm doing 90. That's a 50% savings to meet my costs, and it doesn't affect our plan at all. I think we need to let our people know that there is another option.
Mr. Butch, if you're having issues, feel free to reach out to me. I can have them pull your records and we can research it to see where there's a discrepancy, because most members have either had a like or a reduction in their prescription savings. But certainly reach out to me. I'll help whomever and we'll do a follow-up on it.
Okay, well, Trish, what I'll do is I have the information that I need. I'm going to meet with you and just show you what I did, and I went through with it. I got the 180 pills instead of the 90-day script. So, but I'll bring it to you. Excuse me. I'll bring it to you and show you what's going on. I've got all the numbers, and my savings is going to be right around 50%. Now, some of them are not. I have some old line medicines that my 90-day script, to give you a number, my 90-day script is $20, and then the 180 is $40. Okay, so there was no difference there. But on some of the other pills, it's like 50%.
Definitely follow up with me, because I'll give you an example. We've got active members that have similar situations to that, to where a formulary may have come through with the CVS Caremark or RX benefits, and they're deciding to purchase outside of our plan through Good RX for prescription coverage for one reason or another, just based on the formularies that have passed through that prescription plan too. But I can certainly look into it and research it and get back with you.
Sure. We're glad to do it.
And for all of you on the call, Good RX is a transparency tool designed to tell you where to get your medications for the lowest cost in any particular area. So for those of you who do not have that, that's always a good app to have on your phone, because it can save you some money. Even if the cost of your prescription hasn't gone up, or if it's gone down, it tells you where the least expensive facility or drugstore or chain is that has the particular medication. So it gives you some good cost information.
And you're absolutely about that, because I'm in my research, basically, believe it or not, Kroger's looks like it would have been the lowest cost medicine. Okay. But then again, of course, they're not here in Lafayette, but I did find that Albertsons is very close to the better prices, and the higher prices I find are with Walgreens. Just is what it is.
Mm-hmm.
So that's
all depends on the medication.
Trish, I got today from a copy of a post on Facebook with a retiree having trouble. And Butch, I'm going to ask you, if you don't mind, to look. I don't want to give her name on the Zoom call, but if you look at the retired teacher Facebook page, there's someone having trouble with silver scripts, and maybe you can contact her and direct her to Trish. It has to do with using a coupon or the inability to use a coupon, but you'll find it on your Facebook page.
Well, she may be having a problem using it at a particular drugstore. Okay, I brought a bunch of mine to Albertsons, and they took it. I mean, it was just the transition was, transparent, no big deal.
Well, if you can check your Facebook page and contact her, I would appreciate it.
Okay, will do.
Thanks so much.
Mm-hmm.
Miss Nancy.
Yes,
You had
ma'am.
Mr. Centani and Miss Mary Morrison joined during this conversation.
Great. Thank you, Trish.
Nancy,
Yes,
Nancy,
Yes, Karen.
I'm still looking at the summary page,
Yes.
and I'm concerned about that 5% premium increase, and I'd like to explain why. I worked with a retiree, I'm going to say last month. She asked me to read a letter that she got from the Louisiana retiree system that told her that the amount of money she was getting monthly had her at the poverty line. And because her income was so low, she was one of the few people that they were going to get like a $200 increase. So my thoughts are, we have a lot of people at the poverty line trying to just meet the cost of paying LPSS self-insurance. I've said, and I'm sure a lot of people remember, I'm always an advocate. What can we do to reduce that 5%? I've come here and I've asked, let's not hit people with a 5% at one time. Can we gradually do it? We've had we've had benefit decreases, we have premium increases. Now we're looking at a 5%. That's going to hit the elderly very, very hard. So I'm going to ask again, can we look at, don't come to us with a 5% increase. Can you come with a gradual increase? Every year we're going to increase it by 1%. It's going to be increased by 2%. But to hit somebody at the poverty line with a 5% increase, to me is just, it's not good.
Thank you, Carol. Your point's well taken. Anyone else have questions on this page before Mr.
This is Katie. I do have a question of Lynn. Lynn, with this Blue Connect, I just want to clarify and make sure I'm understanding correctly. Blue Connect means that you will, or someone with your firm will negotiate with auctioneers, doctors, and services, but that does not force people to go. They can still keep their doctors they had, even though they're not connected with auctioneers.
Absolutely. So we all know that, especially with the makeup of facilities around your particular area, there's several different facilities, and these contracts are already in place. So auctioneers has facilities all over the state that they have partnership or ownership of, obviously, Lafayette General being one of them. And the design of the benefit structure is just to have some small steerage there, but wouldn't be decreasing any of the current benefits. There would just be a carrot approach, no stick approach on that whatsoever.
Okay, that's what I understood, but I just wanted to clarify to make sure everybody understood that. Thank you.
Mm-hmm.
And Lynn, I want to clarify the second one, the pharmacy benefit management renegotiation.
Mm-hmm.
That is not going to affect the formulary at all, and it would not affect pharmacy usage at all as well?
Yes, ma'am. That's the design of the of our marketing. And if in fact there's any discrepancy whatsoever in that formulary, that will be identified and it'll be totally transparent.
Okay, anyone have any more questions before we go to the meat of the report? And at the end, I'm assuming, Lynn, based on Burnell's comments, that you want direction from us as to which of these you should come back to us with more information and for a vote. Is my understanding correct? Right.
So in all of the discussion that we've had on this page thus far, the implementation of a 5% premium increase, that particular bullet was more for plan, just for information. I am not in any position to be recommending a 5% increase right now. The benefit changes are, we always want to have those in the hopper in case these weekly claims runs, monthly claims continue to ramp up on us. So we have plans or contingency plans to keep the plan financially stable. The two bullets with regard to the Blue Connect and the pharmacy could garner us some good savings, build up our plan surplus, and stabilize the cost of the plan, and not affect the benefits or change a formulary or anything like that. So moving on those for an effective date of the first of the year would be prudent, because the theme of this, and this is just right at the right time, and we're going back to the reporting, the theme of this reporting, like we have a theme pretty much on every time we meet, you're going to see throughout these pages that as of the end of June, we've got a little bit of decreased cost, and on a plan year basis, a small surplus. But I can tell you, the weekly claims runs of the last few months have really been ramping up, and a lot of that has to do with pent up demand from the pandemic. So when we've had themes in the past, our themes have been the increases in claims have been predominantly from an increase in high cost claimants. You'll actually see that we've had a decrease in high cost claimants, but we've also had an increase in just utilization, and that's reflective of pent up demand. So for example, a lot of circulatory procedures were postponed, and that's being caught up now. Different things like that you'll see throughout the pages of this data, but we need to be prepared for that increased cost. So that's the reason for the strategies, and you guys asked for those to be prepared, and that's why we have them here for you.
Lynn, you mentioned costs relative to COVID. There was some discussion at the end of last year at our last meeting about funding for COVID that was going to the school system, and whether or not any of that would be applicable to the fund balance of the insurance fund. Does anyone on the call have any idea what the status of that is?
Of whether or not there would be reimbursements back to the plan
Correct.
From government?
Correct.
Well, the cost of your vaccinations and tests, that's all paid for by the government, but any COVID claim per se is not being reimbursed by any government agency. And I ran some data on this, and as of August the 16th, I can tell you in this tract at the beginning of COVID, since 3/1/2020 to 8/16/2021, we've had 1,126 cases, 37 hospitalizations, and $839,952 in COVID claims.
And none of that is reimbursed from funds that went to the school system. It can't be used for insurance purposes.
Not to my knowledge.
Thank
Ms.
you.
Nancy, are you asking about the ESSERS funds? Is that what you're asking?
I'm asking for whatever, I don't know the name of them, but the COVID funds, I don't know if it's PPE or whatever funds the school system gets to cover their COVID expenses.
My understanding is that ESSERS funds are directed by the superintendent. I know that we had a small discussion about it a couple meetings back, and you had asked that same question. You had made a statement with regard to it, but as far as reimbursements from it, to my understanding, it still comes from her. And that would have to be a further discussion from Ms. Trosclair.
Okay, thank you very much. Lynn?
All right. So we're at our reporting here on page 1. And I'll take you through the top here. You can see the first column, January to June, compared to all our previous calendar plan years here. Currently, our participation is very stable. Not changing much at all from 5688, 5690, obviously. Very, very stable participation. From a paid claim standpoint, medical claims have actually been very stable. And of course, these are gross medical claims at 16.5 million compared to the 32. Very, very stable. Same thing with prescription drugs. Our total claims at 26,542. You can see in 6 months and doubling that, we're right where we were from the 2020 year. But what's really changed is the plan reimbursement. So the first part of this theme is our claims are from a gross number standpoint are very similar to 2020. But what's really impactful here is our plan reimbursements are almost 3.7 million at a half a year versus 5,676,000 the year before. So it's our plan reimbursements that have really increased, and the majority of that are the additional prescription drug rebates that we've received there. Our retiree drug subsidies are up a little bit. Our net paid claims figure actually down, doubling that figure at 44 million against the 46 million. You can see where the savings are coming from. Fixed cost is about stable, or actually a little bit down. Total plan cost is down some 4.4%. So when we compute that cost per employee per month, we've gone from $750 in 2020 down to $717, which is reflective of a 4.4% decrease. From a funding standpoint, doing better with our funding. Our funding at 25,525 compared to the 49 before. You can see that we've made some increases there. Net employer cost is down. Budget loss ratio obviously down, and the computed surplus just based upon pure claims and claims costs, fixed cost, and reimbursements at $1,060,000. Second page gives us a better view of this because it brings into the picture all per employee per month numbers here. So from a medical claims, well, participation once again stable. From a medical claim standpoint, we've gone from 501 to 503. Not much of a change there. Prescriptions actually down from 310 to 307. Our total paid claims almost equal, 811 down to 810. Where I told you we had the big change was in our reimbursements. Our reimbursements have gone from $86 to $113. Folks, that's a 31% increase. Where's that coming from? The additional rebates on our prescription drug side. That brings our net paid claims figure down to the 677, which is a 4.4% decrease. Fixed costs very stable, going from 61 to 60. Total Blue Cross costs down pretty significantly at the 769 to 737. If you remember, we had a 6.6% decrease on our Humana premiums. That's reflective of the 242 down to 226. All of that married together brings us to the 4.4% decrease from 750 to the 717. Funding, we can see that our active and retiree contributions went from 220 to 224. The bigger increase on the board side, obviously, up some 3.8%. Increase to the board from 505 to the 524. So our funding's increased on average 725 to the 748. Our surplus at $31 per employee per month. Looking at month by month data on page 3, we can see that really our big month of June and capturing that quarterly rebate of $2.1 million has really helped with the surplus. That brought us basically from deficit to surplus, but you can see January claims at 3.1 on the medical side, another high month in May at 3.2. I can tell you when your weekly claims go over $600,000, that's higher than average week, 550 to 600, and we have had some multiple weeks that have been in excess of that amount. So that's why we're really watching that. That's why we have the cost saving strategies prepared for you. Updating just through July, I'll tell you, we've got preliminary numbers there, and July looks to be close to a break-even month. The net claims figure was about $4 million. Total plan cost at 4.4, and then of course we have 4.2 of funding, so we had about a $260,000 deficit in the month of July. The next page, of course, is just our prior year for reference, and then that brings us to fiscal year on page 5. This is the page that we revised, and we wanted to make this revision so when we talk about fund balance, when we talk about accounting from your accounting department, we receive our reporting on what we call a paid basis, okay, of when that claim is paid or when that reimbursement is received. Your accounting is done on an incurred basis, slightly different. So we wanted to make sure that our numbers matched with Heidi's and Matt's, and so we made some revisions and captured these numbers on an incurred basis. And you can see as of the close of the current fiscal year, June 30th, 2021, our past fiscal year, we closed with a deficit of a little over $1 million at $1,026,663. Predominant reasons for that deficit were August, December, and then of course May here of 21. So you can see that we've done better since we put in our some of the changes, and of course to increase that funding and whatnot. So deficit predominantly from claims activity in 2020 there. Enrollment on page 6. Once again, not much to speak of there. Your enrollment went down about 0.3%. Membership, remember, enrollment's the number of employees and retirees. Membership is the number of bodies in your plan. Membership actually went down 0.6.
Lynn, if we could go back to the previous slide, I just want to make a comment because I don't want any surprises when the actual audited financials come out, because when the auditors get here, they're going to start looking at claims that were not paid, that occurred, that are paid later but occurred in June or in fiscal year 21, and they often make an adjustment to that number. So we have a standing number that we estimate that to be, but based on the higher claims that we're seeing in the months after that that you just showed us, we might have that increase. So I just don't want the committee to be surprised if that 1 million, when they see the actual financials, are more than that. That number is pre-audit, the pre-audit number.
Matt, what is the fund balance of the insurance fund? I see what the plan deficit is. What is the current fund balance in the fund?
Heidi, you want to comment on that number? I think we looked at it this morning. It was about 3 million. I think Heidi got her mic working. Maybe not.
Maybe she can send you a text.
I believe it was about 3 million. So that knocks it out by a third, depending on what the auditors come in and find. I was just a little
Matt,
concerned when I saw some of the big checks. Is that you, Heidi?
Yes, can you hear me? Hey.
Yes, I can hear you.
Okay, yeah, that is correct. I believe it was a little bit over it was around 3.6 million. And then after this 1 million deficit, I believe the ending number was around 2.6 million for fund balance.
Okay, thank you, Heidi.
Uh-huh.
I just didn't want any surprises. I just wanted to make that clear.
Thank you, Matt. So back to enrollment, and as we've spoken before, membership is not outpacing enrollment, so no real problems there. Enrollment by plan on page 7. The enhanced plan is participation has been stable from previous years and remaining at or around that 15% or so. Your basic plan has had some decrease of about 1.9%. And then, of course, Blue Saver has had some increase with regard to that. Page 8, membership decreasing less than 1% at 0.6. And then, of course, we get to our medical claims on page 9. And a lot of information on here because, you know, when I mentioned to you in past meetings where we've had some uptick in claims, and, you know, at one I can remember some of the meetings, it was high cost claims and it was cancer. In this particular situation, we actually have a decrease in high cost claimants. You're going to see in further pages a decrease in inpatient hospitalization, but from a utilization standpoint, I believe we've got some pent-up demand that we're running through right now, and the hope in that is once we run through that pent-up demand that we would see a normalization of claims, which would present a decrease in claims figures. So if you look at the first bullet here, medical claims are stable, increasing less than 1%. But when we look at these next couple, they're currently, when we talk about claims between 2,000 and 20,000, and we're measuring the same period of time, the first 6 months of 2020, first 6 months of 2021. Okay, so we're not comparing to like a full year or anything like that. Same period of time. 1,026 members, totaling 5,913,000 compared to the 804 at 4,006,000. That's $1,280,000 difference. Then when we get to claims on the next bullet here, 148 compared to 111. And that difference is $1,152,000. Now, when we get to larger claimants, over 100,000, 16 compared to 21, and pretty big difference, $1,658,000. So we can see that pent-up demand, just higher utilization, is the story of the medical claims. On prescription drugs on page 10. Decrease of 1% and a decrease while we've had an increase in high cost claims, and while all plans should be expecting increases on prescription drugs because of the trend increase in cost, all of that type of thing. Not happening for us. And of course, these are gross numbers. This is before any reimbursements. So we've actually had a slight decrease in just gross claims, and that's because of the contractual discounts that we've garnered through the plan, and a little lower utilization as well. From a total claims perspective, almost equal at 810 versus the 811. And then total paid claims net of plan reimbursements, because our reimbursements have increased so much, down some 4.4%. Page 12 gives us information on the performance of the 3 plans. About midway into, or the second set of bullets, you're going to see the enhanced plan now has 15.3% of your participation, 21.8% of claims. Basic, 62.3, 66.7% of claims. Blue Saver, now up to 22.4, represents 11.5% of claims. Also did some requested work where we knew that we have claim savings when we compare Blue Saver to Basic, Blue Saver to Enhanced. At the same time, we have less contribution when somebody moves. Now, the more people that move to Blue Saver, the more that gap closes, because remember, we're talking about 62.3% of folks, in that basic plan. But if you look at the bottom three bullets here, the claims cost savings, okay, and I've looked from 2018 to present, and the claims cost savings between the basic PPO, okay, and Blue Saver are $452, while the difference in contribution is $525. So if we actually lose a little bit on that. On our Blue Saver compared to Enhanced, the claim savings are $779 and the contribution $724. So we're making money on that one. Bottom bullet, the range is claim savings is $452 to $779 versus the contribution of $525 versus and $724. So it's very close, but as we increase, and what I saw each and every year is that gap closes while we have increase, because most folks that are joining the high deductible health plan or Blue Saver are single, okay? While most of your family folks. And the other thing is we were able to do this based upon some averages of single and family, and it really doesn't get into the pure detail of how many are employee plus one versus employee plus two or more. That data, we would have to have done some manual reporting on that. That would take much longer to prepare for you. So to answer your questions on that, it's pretty close to break even, but the more folks we have into the high deductible health plan, it's going to save us money because it gives them the opportunity to be consumers, lower their claims even more, all of that type of thing. On page 13, total costs down that 4.4%. And I'll take you to the bottom bullet here. Your plan costs increased on average of 2.5% since 2012. And guys, I'm telling you, that is phenomenal. Trend, even with changes in your benefits, during that period of time averaged about 6-7%. So if we put 6-7% since 2012, that $52 million of expense that we saw would be a whole lot more. So really good job on controlling these costs. And when we look at claims by type of service on the next page, it really shows even more that I believe the costs that we've seen lately are indicative of pent-up demand, because you can see that we've gone from 156 to 131 and a 16% decrease on inpatient hospital utilization in a time where inpatient hospital utilization should have increased on us because things were a lot more opened up during this period of time than they were last year. outpatient increased some 9.6%, and that's where I think the data points towards that pent-up demand. Same thing with professional claims, doctors, diagnostic work, things like that, increasing some 6.6%. By top diagnosis on an inpatient, circulatory, number 1. Musculoskeletal, number 2. But musculoskeletal is actually down. Injury and poisoning actually down. Circulatory up. Other categories that are up is pregnancy and childbirth. That's up on everybody's claims data. I think that's indicative of the stay-at-home order. You'll see that neoplasm is actually down a bit, okay, which was something that we were discussing pretty regularly. And then, of course, you'll see the other categories. Factors influencing health is reflective of mostly of chemotherapy. On an outpatient basis, factors influencing health is our number 1 category. Circulatory number 2. Circulatory is up, but the factors influencing health is actually down. It's just still our number 1 category there. Nothing else really pointing out to any kind of concern on the diagnostics here. On top facilities, you're going to see we've kind of gone from Lafayette General has been our top facility 2016, 17, 18, 19, and 20. Lourdes is our top facility this year. And of course, that's just indicative of maybe some of our larger claimants might have been there, but they have, are tied there. Also, when you combine Lafayette and Lourdes, the combination of the two in 2020 was $199 per employee per month. Combination of the two in 2021, $212. That's a 6.5% increase. So,
Lynn, are our discounts the same with both of those hospitals?
No, ma'am.
What's the difference?
I am told that the contractual discounts at the general are a little more. And of course, if we were to look towards the Blue Connect, it would even be that much bigger. Prescription utilization by number of scripts. Do not be alarmed that we've gone from 87 to 85. That is indicative of the brand name Moderna COVID vaccination. That's in the data. So it skews it a bit. We've not, our plan members are still utilizing generic to a high degree. It's just the percentage is skewed by the Moderna vaccination, which was in your top 10 meds as far as number of prescription goes. Actually, number 3, you had 1,900 Moderna vaccinations during this period here. From a prescription drug by dollar amount, generic still representing, even though we're using generic 87% of the time, still only representing 14% of the total paid claims, but at least we have a little bit of an uptick there. On number of scripts per employee or per member, down just a bit there, 0.1%. I'm seeing that on everybody's plan. And then, of course, on page 21, these are top 10 by number of scripts, the exact same things of what you want them to be. I will point out to you that you're seeing the bottom 2 there, some psychotherapeutics and hypnotics coming into the plan. That is also indicative of the time and place that we're in, but yours is a lot less than what I'm seeing on other systems. A lot of depression medication, things like that. In open enrollment, we will probably center a little more on employer assistance program and things like that, giving some just for educational purposes to make certain that all your plan members have access to all your benefits. Strong believer in that benefit. It's so easy in this day and age to call a family physician and talk to them about anxiety, stress, depression, and get a hold of a prescription. Whereas in employer's assistance, you're actually talking to a counselor and looking towards a solution for those types of problems that might or might not include medication. Your top 10 drugs by dollar amount on page 22. I'm going to point you to the bottom bullet. It's increased 3.3%, but on the one right above, 3.7% of your medications are driving almost a third of the cost. Just these 10 medications are 30.2% of our total prescription drug claims. They represent 3.7% of the prescriptions. Predominantly anti-inflammatories for arthritis, rheumatoid arthritis, Crohn's disease, plaque psoriasis, and that's going to be the Humana Plan, Stelara, Consentix, those types of medications. You have a couple of cancer medications in here with your Revlimid and Spirosol and also some diabetic medications, and then of course the blood thinners that have hit the market in recent years, Eliquis being number 2 there in the last several years here.
Lynn, are we seeing the $3 million cost savings from SilverScript that you anticipated?
Yes, ma'am. It's running quite well.
Okay.
And that was indicative of the big number that you saw in that rebate in the first couple of pages. When we're talking about PPO savings, 69.6% is probably the highest number I'm reporting on cases your size. Your plan members are very, very adherent to the network. Next page tells us the statistic at 97.8% of all of your claims are paid in network, and 69.6 is obviously a high number there. That number will increase, obviously, if we were to garner the savings of that Blue Connect program. Going to page 25, super important here, folks. Basically, 92% of your plan cost is claims. If we went straight to a carrier, whether it be Blue Cross, United Healthcare, Aetna, Cigna, Humana, any of the majors, that cost, where it's pennies on a dollar now, 8.2 cents on a dollar is dedicated to the fixed cost of running your plan. That would be close to double that amount if we were fully insured. So you're running your plan very, very lean and very efficiently at 8.2%. Administration actually less than 2, reinsurance at 6.3. The only reason you see an uptick in that number is because our claims are actually a little down right now, and it makes that percentage come up a little bit. Very, very cost effective as far as our administration and reinsurance goes. From a contribution analysis standpoint on page 26, Net of employee contributions, we are down some 7% right now. And then, of course, on page 27, we have basically covered this on the medical page, but basically you can see we've had increases across the board in every one of these little categories here, except large claims. So large claims is not our problem right now. It's just increased utilization, which I firmly believe is pent-up demand from the pandemic. And hopefully, when that does normalize, that we see some decrease in these weekly claims runs, which we were starting to see, and then it, of course, ramped up a bit again. In addition, and then of course on page on the next page here, we've got all of this summarized for you for reference whenever you want to come back to it. We've also provided some benchmarking for reference as well. I do want to point out one thing when you're looking at the benchmarking here. And this is just for clarification purposes. When you're looking at that first page in the benchmarking, 29, right? When you look at the comparison of contributions down at the bottom, the categories you see are employee, employee plus spouse, employee plus children and family. And that's the 4-tier criteria that the Office of Group Benefits uses, in many cases you use a 3-tier criteria of employee with 1 dependent, employee with 2 or more. So that's why you see the same number for employee and children and same number for family. So just want to make certain that everybody knows that. And of course, your benefits do compare very well with all of the other entities, especially the Office of Group Benefits. Your enhanced plan provides better benefits across the board. Actually, your basic plan right in line with that benefit, but a far benefit on the prescription drug side. You'll notice that co-pays don't come until you've reached the 50% mark on the Office of Group Benefits. So I also included, after the benchmarking, your current plan benefits that you can see: basic, enhanced, and the high deductible plan benefits there for you. So when you were referencing some of these strategies, but once again, the strategies that we presented, and we talked about these prior to anything else, benefit changes are always on the table for consideration, but at this particular time, benefit changes would be more for consideration if we continued to have some increased costs. The Blue Connect and the pharmacy benefit management, because they don't have a negative effect on benefits or premiums, would certainly be in order for a 1/1 effective date if the committee chose to vote on that. As far as the pharmacy benefit management, almost a worst case scenario there would be that the current pharmacy benefit manager would be able to negotiate far further than they would without any competition. So we might well have a situation whereby each and every year, you know that RX Benefits has given us some additional increases as far as discounts and rebates go. If we can garner more by marketing, we'll be in good shape. And then at the same time, we know what the emphasis is behind the Blue Connect. So I'll take you back to the benefits real quick here on page 32. And for example, if we look at the basic plan and you have a deductible of $950, the deductible with a Blue Connect provider would be proposed at or around $800. When we talk about co-insurance at $80, we probably put the co-insurance at $90. When we talk about an out-of-pocket at $5,500, we'd probably put the out-of-pocket at $5,000. So just small tweaks and benefits, and if we can garner an overall medical savings of some 4%, that would be very beneficial.
So, Lynn, as I appreciate the last page, which for us is 34, I think we were off a page different than what you had. The Blue Connect and the renegotiate would not affect benefits at all. And what you're asking is if we agree or if anyone objects to your looking into those and bringing more specifics back to us for a vote?
Correct.
But I would ask that as soon as, and I understand it'd be a good idea to do the research, but as soon as he gets all the research done, for us to have a special meeting so that we don't have to wait right before another board meeting or whatever to make a decision. So as soon as he has the information, that perhaps we could have another meeting just to review that and to give the permission to move on.
The pharmacy benefit management is such an important subject to all plan members. We would not be making any recommendation until we had a finalist presentation to the committee.
Yeah, and I understand that, Lynn, but it's just that whenever you have it done, so that we don't have to make a last minute decision on this. Yeah, you know, that as soon as you have it done, get a meeting, we meet, we discuss it, and we go forward with whatever. And it's just so that it's not a last minute thing that has to be decided where there's no change, and then the next day you find out there's something else. So I'd appreciate, personally, I would appreciate that.
From a timeline standpoint, that that work would be completed, and we would be more than likely making presentation or finalist presentations early part of October.
Okay.
So that would mean we would have 2 meetings in October. One to just deal with Lynn's recommendation and specifics. Does anyone object to, I don't think we need to vote because we're not actually going to vote on anything tonight. Does anyone object to Lynn pursuing additional information on the Blue Connect and the pharmacy benefit management program to present at an additional meeting in October? Is there any discussion on that issue?
I think that'd be a great idea. I think that's the two places that we will see the least amount of anxiety amongst our members. I mean, nothing's going to change. We'll just get a lot of the rebates and a lot of the savings from that. So I'm for it.
Any other discussion?
No, I agree. As long as it comes back to us, as Burnell said, in a timely fashion so that we can look at it and make an informed decision.
Lynn,
yes.
I'm sorry. I was just going to mention, Lynn, we discussed when we did market that PBM program that type of change could be done off anniversary because it's not, you know, it's really just a new ID card once the analysis is complete. So you wouldn't be rushed into making a decision at all. We definitely want to do a thorough analysis to verify that everything is intact.
So Lynn, if I'm understanding, we're looking at a fund balance of around 2.6 and the Blue Connect could give us 1.3 and the lowest pharmacy benefit management savings you're considering is 1 million, which would bring us to 4.9. Is that correct?
Yes, ma'am.
If no one objects, we will ask Lynn to come back with additional information. And I would ask, if it's at all possible, we got this report yesterday and the revision today, and a lot of people didn't get to see the revision until tonight. So if we could get the revision the week before you want to have a meeting, so especially active employees who are busy working, not that retirees don't also work. If we could get it several days in advance of the meeting, we would appreciate it.
Yes, ma'am.
Lynn, on the $1 million loss we had last year, and I just looked real quick, we had a $3 million loss the previous year and $1 million loss the year before that. So, you know, this will, in essence, if everything stays the same, this will give us a break even plus a little bit of a cushion. Is that enough of a cushion for what you expect maybe in claims or inflation for the next coming year? I just don't want to get to the, you know, we have $2 million, but that can go very quickly from our fund balance. Is that enough to put us into a more comfortable situation?
That's why we have the second set of benefit strategies in the event that it doesn't. But I can tell you what, I did do some additional analysis on this, and basically, if we, based on the assumption of continuing our current level of claims, and that, you know where our claims are currently, if we keep having the same level of claims that we're having right now, the net claims estimate for at the end of the year is just right under 45 million. If we utilize that number and total plan costs with the Humana retiree premium would be 49 million. And our funding is at 51, so I think we would be okay.
And we didn't have the SilverScript savings in prior years, which should continue, I assume, Lynn, into future years.
We had a half year of it in this year, about a half year.
Mm-hmm. So looking at projecting the rest of those rebates out, utilizing current claims, to answer your question, Matt, I think that we would be comfortable with what we see here in Blue Connect and the pharmacy benefit management, but we need to be vigilant in that to have additional saving strategies prepared in the event, and folks, in most cases, your case, because we have so much data for so many years, is pretty predictable. I can't tell you that right now.
Yeah, and I like to put, you know, something Carol said at the beginning, you know, I want to try to avoid a big one-year increase, you know, by making tweaks and adjustments on small annually. It kind of it allows you not to have that big year where you get against the wall because we have a couple of high cost claims that push us over or something, and we don't have much cushion. So, you know, I just want the members to keep that in mind, that, you know, we're not doing an increase. You know, you said the 5%, but you know, some of these other changes that don't affect as many people, we may want to still keep in consideration, because we don't want to be hit with a big increase in one year rather than small increases over time.
Right.
As Carol
Well
did.
said.
Lynn,
Can I just
I was going
want
to
to say, I want to say thank you, Matt, because I want you to really remember, I've been asking, let's not hit retirees, active people with a huge increase. I'm asking for 1%, 2% a year. Just don't hit us, because I'm feeling the pain that you're going to come back and say, okay, now we're in the crunch, we're going to have to do 5, when I've been asking this for many, many years.
So Lynn, when you come back, if you should come back with something other than just the Blue Connect and pharmacy benefit management, could you come back with the cost of a 1% annual increase and a 2% premium increase? Both a 1%, a cost savings for 1% and 2% if that were done on an annual basis.
Not a problem.
Appreciate it. And that will address Carol's concern, which she has raised several times, several years in the past.
And once again, the 5% premium increase, obviously you can tell from the rhetoric during the meeting, wasn't any type of recommendation right now. I'm just putting that down for information purposes so that you guys could see what that would garner. So basically, 1% I can tell you right now.
150,000.
Right.
152.
So that might be something the committee wants to consider at some point, rather than doing these tweaks to the max out of pocket or deductibles for just parts of the plan. If we did a 1% or 2% on an annual basis till we built up our fund balance to a certain point, that may be something the committee would want to consider as well.
Correct, because a 2% increase would save you from having to increase some deductibles.
Correct. Right. Anything else from Mr. Fontaine? Questions or comments? Well, as soon as I hear from you, Lynn or Trish, whoever's going to let me know, we'll schedule the meeting in early October and expect to get whatever data you have to present the week prior to that meeting, if that's okay with you. All right, next item on the agenda is Trish LaBeouf on the insurance department and contracts.
Hey, Miss Nancy. The only change that we have with regard to contracts since the last time that we met was the EAP services that we offer for our employees that Lynn even touched on during his conversation that he had earlier. EAP is basically the employee assistance program that allows employees to seek free counseling. The school district essentially pays for it. It's offered to both their employees and their family members within their own household. So we did renew that contract. It is a 3-year contract. It still came on at the exact same rate that we had previously, per the number of employees that we have. And we'll hold that rate for a total of 3 years, and then we'll revisit the contract again. So it will go all the way from 7/1/21 to 6/30 of 24.
Thank you, Trish. Anyone have any questions for Trish? If not, we'll go on to the next item, which is, I don't know, Trish, if you're handling dental or if someone from EBI is handling.
Ms. Nancy, I'm going to be discussing dental this evening. I've got EBI had a scheduling conflict that would not allow them to present this evening. So I'm going to go ahead and review everything that they've already reviewed with Ms. Gardner, Mr. Mouton, and me earlier this week. So let me go ahead and pull that up. Hang tight just 1 second.
Trish, do you want us to stay on, or it's up to you? We'll stay on if you want us to.
Brooke, you're welcome to leave. We're just wrapping up dental to discuss that through. There's nothing else on the agenda with regard to HUB. I appreciate your time.
Yeah, no problem. You guys have a great evening.
Thanks, Brooke and Lynn.
All right. Look forward to seeing y'all in person someday soon.
Yes.
Take care, Lynn.
Good night.
Good night.
Okay, Miss Nancy, can you see my screen? I've got the dental providers. Okay, I've got the dental providers that EBI reviewed with us. So essentially there are 9 carriers that were requested to bid. Of those 9 carriers, we had 5 that responded. We had Dina Dental, Aflac, Humana, Emeritus, and then Delta Dental gave 2 options. The other members that, the other carriers rather, that decided not to provide an offering was Unum, Lincoln, and Blue Cross Blue Shield of Louisiana and Guardian. So a total of 4 declined, and 5 we have presented on the chart that you see on the screen. So I just want to try and give you some back history first and talk you through it so you know the numbers that we're talking with regard to active members. Active employees that are currently on the DINA High and Low Plan, there's 2,451 members. The retirees that are currently on the DINA High Low Plan is 274 members. And then we have a grandfathered group, which you'll see down here at the lower screen, of retirees that are grandfathered on the DINA plan that's very similar to what the active and retirees have. It's not an exact replica, but there's 373 members on that plan. Just to try and give you a perspective of who's on it based on the DINA current dental that we have. So DINA, I'm going to zoom into the DINA portion and then I'll zoom back out as we discuss them. DINA has offered a 10% increase in rates for a 1-year rate guarantee for both active and retired and the retiree grandfather plan. So if we stick with DINA and we decide not to make any changes, you've automatically got a 10% increase for all of your members. Okay. The plan benefits, everything would remain the same. We wouldn't make any changes to the plan. Members would just have a 10% increase. Okay. The next one on the screen is Aflac. I'll zoom into that one. Aflac Plan mirrors the DINA dental plan exactly. Aflac instead is offering a 4.5% increase for the active and retired members and a decrease. Let me zoom down. We have a decrease for the grandfather retiree members that I discussed. They are offering a 3-year rate guarantee, and Aflac's network that they have uses Dentamax, which is the exact same network that DINA Dental utilizes. In addition to the Dentamax, they are adding additional in-network providers. Upwards, we did a radius of about 20 miles, just concentrating on the Lafayette radius, of approximately 102 just for that area for in-network dentists that would be added if the election of Aflac happened. With regard to the members that are under the Aflac plan, they would all be considered in-network if they attended those dentists. Please stop me if you've got any questions. I'm just going to keep rolling through each of them, and then I'll tell you additional information and answer any questions that you may have. The Humana Plan is the next one on the chart. Humana Plan mirrors the dental plan, the DINA dental plan exactly. However, they do have a 16.9% increase for members, both under active, retired, and the retired grandfather plans. They do have a 3-year rate guarantee if the Humana option is chosen. Emeritus, the one in purple on the screen, did not offer an exact comparison. I should stop for a second and tell you, essentially, EBI went to DINA Dental and these providers and asked them to provide an exact current dental plan that we have currently, and then to offer an alternative. So the ones that I mentioned earlier, the Aflac and the Humana, offered an exact replica. Emeritus, when they offered to EBI, they did not have an exact comparison. They had something that was different. So if you look at the Emeritus, they would have an 11.8% increase under the high plan and a 2.3% increase under the low plan for the active and retirees. And then Emeritus, with regard to the grandfather plan, would see a decrease, a 7.2% decrease under our retired grandfather plan. Emeritus is offering a 2-year rate guarantee with those 2 prospective increases for active and retired members, and then a decrease for the grandfathered retirees. Emeritus Low Plan is similar to their High Plan, very similar. There's not enough distinction between the two. If you look at the chart, it's very similar. It would be difficult, in all honesty, if members took a look at this, their first eyeballs are going to go to, well, what makes them different? They're very similar. You're going to have, members will likely choose the lower plan because obviously the cost will be lower with regard to the premium, than electing the high plan with almost the exact same offering. So that is of a concern. If you look at the chart, it tells that there's not much distinction between that high and low plan based on the offering that they provided. The in-network, ma'am? Okay. The in-network providers would increase. Emeritus doesn't include the current providers that Dina has, but there is an overlap of the current dentists, and it would expand the network by 96 dentists for the Lafayette Parish area alone. More in-network dentist additions would allow members more of a choice and duly lower their out-of-pocket costs and stabilize the group claims.
Trish, did you say that it was not the same network of dentists?
It is not the same network, no ma'am, but it would increase the amount of the network by 96 dentists. We looked at the Lafayette Parish area, we keyed in the 70508. So it's not Dentamax. However, they're in-network providers based on what current Dina offers for in-network would increase the plan by 96 providers.
Let me question this way. Would anyone have to change their dentist?
Based on this and the fact that they do not allow Dentamax, their Dentamax is not considered in-network, the answer would be yes.
Thank you.
Okay. The last one on the chart is the Delta plan. They offered a plan A and a plan B. They did not offer an exact comparison to Dina's current, but they did offer, the A has an increase of 2.66 for active, retired, and grandfather plans. Plan A, the percentage paid per service offering is lower than the current plan and the same for the grandfather plans. It would require more out-of-pocket for members based on the percentage of reasonable and customary. Plan B, the last one at the end, did have an increase of 7.75%. The percentages paid by the services are lower than the current plan. It would require more out-of-pocket, the same scenario. Plan B also had a lower annual maximum amount. If you notice on the chart, one says 1,250 and the other says 750. Our current Dina plans are 1,500 and 1,000. So you're reducing the members by $250 annually based on where they would max out. So keep that into consideration as well. Ma'am?
I didn't know if you were finished or not, Trish.
I was going to offer a little bit more back history and tell you, since EBI did meet with staff, I was going to run through the recommendations both by staff and broker and try and break it down for you so you could understand it a little bit more. So after looking at it and reviewing all the options available, the broker and staff both recommend Aflac based on the offerings, and I can zoom back out so you can see everything. The premiums continue to increase because there are more members utilizing out-of-network dentists. The recommendation to switch to Aflac is based on the least disruption to members, the least premium increase, and the broadened in-network dentist, which would lower the members' out-of-pocket costs. Most times what we hear from members when they call through is there's not an in-network dentist that they can go to. So therefore, they're paying a premium, and when they go to the dentist, they often have to pay more because it's not in network a majority of the time, not always. And then their costs are increased due to the fact that they're having to pay when they go to the dentist as well. So that's the most, if I had to list something that staff tends to hear over and over again, it's the in-network dentist. So if you selected Aflac, rates would increase by 4.5% versus 10% for active members. there would be a 3-year rate hold versus a 1-year rate hold. The in-network providers would also increase to include for ortho and oral surgeries. Choosing in-network providers would in turn stabilize your group claims, which would in turn help you at renewal, because that's what the issue is right now. You've got a lot of members going outside of network to see the dentist within DINA because they just don't have them in network. Retirees in turn would be able to see just a 4.5% increase versus a 10%. The retirees under the grandfather plan would in turn see an 8% reduction in their rates versus a 10. A 3-year rate hold versus a 1. And again, the in-network providers would increase. And we did do a double check with regard to pension. We'd still be able to maintain retiree pension deductions through teachers' retirement. There are 513 retirees under a pension deduction for DINA. And with regard to direct bill, retirees, there are 134 under direct bill. Those tend to be your members under Louisiana School Employees Retirement. We'd have to go back to those members and get new ACH or credit card information, but that's certainly doable prior to the changeover of 1/1 if you were making that consideration. And just one other thing I'd like to touch on, which is a definite long yop, is the fact that there were 2 carriers that also provided vision as an offering. EBI went back to Superior Vision, told them of their offerings because they were offering a decrease with regard to the Superior Vision premiums. And Superior, in turn, has provided a long out to everybody for next year. And the fact that they're going to be reducing premiums by 5% for active and retired members. They're going to offer a 2-year rate guarantee and increase the allowance of frames and contacts from 125 to 130. So a bonus out of all of this, just by reviewing the dental, is that in turn, we're going to have a reduction for vision just by a simple request.
And Trish needs a decision tonight on this because of open enrollment. Is that correct, Trish?
Yes, ma'am, we do. Based on the date that you picked for, or based on the data that we had for HUB, I know that this date was picked for that purpose. So we've got open enrollment right around the corner and we do need to move forward with it. By it going to the board on the 1st of September, it's going to put us in a little bit of a crunch, so we definitely can't delay it past that point.
What are the wishes of the committee? Anyone have a motion? Trish, can you take down your screen if you don't mind? Does anyone have a motion? The recommendation is from the staff and the broker is to change to Aflac.
I make that motion. This is Clyde.
A second.
Clyde made the motion. Who was the second, please?
Me, Matt.
Matt Dugas was the second, Donna. Are there any emails, Trish?
No, ma'am, no emails.
The phone number is 521-7064, and we have our very long minute to wait.
Nancy, while we're waiting, let me ask Trish, can we get a download of the in-service or the in-network dentist, a listing of that?
Yes, sir. I actually have it on my screen. I figured that might be one of your questions. I can certainly send it to you, or I can provide it. I can share it on the screen, whichever you prefer.
Why don't you send it to Trish?
Okay, that's not a problem. I did the Lafayette area, but there's obviously more parishes. Members use outlying areas, but it would definitely increase your network.
Okay, well, if you could, I think sending it to everybody, at least we will have an idea in case we get some questions from other members, you know, from some other retirees. So yes, please send it to everybody.
Okay, that's not a problem.
And our minute is up, so all those in favor of switching to Aflac Dental, say aye.
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 Anyone opposed? So the minutes will reflect that each member voted in favor of that.
Yes.
Is there a motion to adjourn?
So
That's the
moved.
Second.
Okay, who is that?
Who is the motion? Butch made the
Butch,
motion.
yeah.
Okay, Matt. Okay.
Matt was the second.
Yep.
I don't know if we need public comment on this or not, but we can. All those in favor?
Aye.
I am tired.
Thank you, everybody.
Good meeting.
Thank you.
Take care.